Good afternoon, and welcome to our very first edition of Fertility, Fact or Fiction. So I've decided to do this because in the world of infertility, there are a numerous number of treatments and adjunct treatments that are offered to try and assist patients to conceive. Some of these have tremendous benefit, and we use them and we employ them to the benefit of patients. And sometimes they're low cost, sometimes they have a significant cost, but ultimately they're of benefit. Other treatments don't have as much benefit, or there's not as much evidence to support them. And so sometimes in the effort to try and help patients, we start incorporating these, but they may not be that beneficial to you. What I want to do is break these down for you guys by doing the research for you, going through the text, going through the literature, finding out what really does work, what doesn't work, and then presenting that to you to make your decision process easier when you're deciding to go through with fertility treatment. This way, if there's something that works, you'll know, and if there's something that doesn't work but it's being presented to you as an option, you'll also know, and that way you can protect your resources, whether they be time resources or financial resources, or sometimes even just the psychological component of doing the procedures. So we're going to start off this week with a topic of pre-implantation genetic testing. So the short form of this is called PGT, and specifically for the majority of patients out there, they're doing something called PGT-A, which just means you're looking at the chromosomes in your embryos. So every human cell should have 46 chromosomes per cell, and embryos are no different. In each individual cell, they'll have 46 chromosomes. Now, those 46 chromosomes have to be matched pairs of 22 chromosomes, and then either an XX if you're a female or an XY if you're a male. So 23 pairs total. Sometimes we get embryos that don't have a balanced set of these chromosomes. They're either missing pieces, or they have missing whole chromosomes or extra chromosomes. And we can now detect those changes or those abnormalities using this pre-implantation genetic testing process. So the embryos are grown out to day 5 or day 6. The trophectoderm, which is the outer cells around the embryo, not the baby itself, but the material that becomes the placenta, gets biopsied, and those cells can be tested to see if your embryos are normal or not. So I'm sure many of you are asking, why is this important? Well, the reality is that in young patients, the number of embryos that are abnormal is relatively low, sometimes as low as 30%. But in older patients, and by older we're referring to even as young as 35, the rate can become as high as 50 to 55%. And in one recent study, they demonstrated that by age 44, they found no genetically normal embryos. Now, that's just one study, and I want to reassure those of you who are older that there's still a chance of producing normal embryos, but it is more difficult. By selecting embryos that are not abnormal, in other words, selecting your normal embryos, we improve your chances of success, or at least that's what the theory is, and that's why people have started employing this technique. The important factor, or at least suggestion with this technique, is that we can reduce the chances of failure by selecting good embryos. That's number one. Number two, we can actually reduce the chances of miscarriage by reducing the possibility that an abnormal embryo implants and then subsequently becomes a fetus. And then lastly, and perhaps most importantly, we can reduce the chances that the embryo develops, it grows, becomes a child, and you've now given birth to a child that may or may not have very significant chromosomal abnormalities, some of which can be compatible with life, but sometimes they're not, and you can go through the whole pregnancy not knowing and then be caught unawares at the end. So the proponents of PGT say that it should be done because we can have all of these reductions and complications. So what I wanted to do is review the evidence with you today, and that's what we're going to do. So the first study examining the use of PGT-A for patients who were good responders was done by Scott et al. And this was a study called a randomized controlled trial. So the technique of the study is really important. Number one, this was the first study using a modern technique for screening the embryos, which is important. And number two, this was a randomized controlled trial, as I mentioned, which means that they took the women in the study, and they assigned half of them randomly to a control group and half of them randomly to the experimental group where they were actually applying the treatment. So half of the patients received a day 5 embryo transfer with no testing of the embryo. Half of the patients had their embryos biopsied on day 5 and then transferred on day 6. Now there's a couple of things that are really important about this study to remember. Number one, these were all patients that were relatively good responders. The average age was fairly young. They were around 32 years of age, and they were producing good enough embryos that they could make it to blastocyst stage and be biopsied by day 5. Number two, the center that performed this study is able to provide same day or next day assessment of the embryos and then the transfer without having to freeze and thaw the embryos. That's very unusual, and not all centers are equipped to provide that on site. So you have to go to a really big center to do that. And number three, this was a very well-run study. It was very rigidly done, but there were concerns about the fact that it wasn't necessarily real-world application where you were dealing with older patients, patients who are at a higher risk of having genetically abnormal embryos, and then of course the whole question of whether or not the embryos were being frozen. So in that study, close to 80% of the patients who did the PGT, who had the actual embryo biopsy and testing, had a successful implantation versus only about 63% who tried without having the implantation testing or pre-implantation testing. So in that study, they showed a significant benefit. So for that specific group, they were saying that for young women who are healthy, produce good, robust embryos, there is a benefit to doing the PGT-A. In another study conducted by Foreman et al., they did a randomized controlled trial again as well. But this time they interestingly tested one biopsied embryo to 2 untested embryos. So in the group that received the biopsy, they only had the one genetically normal biopsied embryo implanted versus the second group, or the control group, where they had 2 embryos implanted, but they were not tested. So in that study, they actually demonstrated no statistically significant difference, but there was a small trend towards an increased implantation rate in the group that had 2 embryos transferred. Fairly obvious. These again were young, healthy women. You would anticipate that in that group, the patients that are receiving 2 embryos would still have at least 30 to 50% of their embryos be abnormal, so the majority are still normal, and therefore those patients would actually have an improvement in their success rate because they're getting double the chance instead of just the one genetically tested embryo. However, in that study for women over 35 years of age, they showed that in the patients that did have the genetic testing, there was a significant improvement. So the younger patients didn't show anything significant with testing, but the patients over 35 did show a significant improvement, and that number was 58.3% for those that were genetically tested versus 39.8% for those that were not. So the important factor there was a much higher risk of having multiples with 2 embryos transferred, and interestingly, there was actually no difference in the miscarriage risks. So again, remember, if you have genetically abnormal embryos, we're anticipating a higher risk of miscarriage, but this study didn't show or support that. So the last trial I want to talk about is a study by Osgur et al., which was published recently. So in this trial, it was a little bit more real world in the sense that they actually biopsied the embryos and froze them. It was still a randomized controlled trial. They were comparing patients with testing against patients without testing, but the patients all had their embryos frozen. The biopsies were done, they tested them, they figured out which ones were normal, which ones were abnormal. They brought the patients back and did a frozen embryo transfer. This is probably more realistic for most centers because a lot of places, as I mentioned earlier, cannot provide same day or next day genetic testing and then transfer. So in that study, the women were again fairly young, average age was fairly low, they were under 35. The patients were good responders, so they were able to make at least 2 day 5 blastocysts that were considered BB quality or better. And so these are robust patients with good results to begin with. In that study, they actually showed no statistically significant difference in live birth rate. And that's a really important marker because a lot of times in the fertility world, we use different terms. We talk about clinical pregnancy rate, we talk about positive beta HCG levels, we talk about live birth rates, but the real important one is, are you going to have a baby or not, which is the live birth rate. So when these guys tested that, they saw no difference with 56.3% in the testing group versus 58.6% in the non-testing group. So really no difference whatsoever. There was no statistical difference. There is another study done as well. I won't get into too many of the details. Essentially, they showed the same thing, except that there was a benefit in women that were 35 to 40, but not for women that were younger. So overall, the studies kind of go on, and there's more every day. But ultimately, what's important to understand here is that if you're a young, healthy patient and you're producing good embryos, it does not appear that PGT is beneficial for you. Older patients may derive some benefit, especially because they are at a higher risk of having abnormal embryos. So if your risk of having an abnormal embryo is 70–80%, which can easily occur when you're in your 40s and above, then certainly it's worthwhile because you want to limit the number of embryo transfers, the cost that goes along with it, the emotional roller coaster, all of the injections, the pain, the suffering, and so on. But for younger patients, it really does not appear to be that beneficial. Are there exceptions? There are. If you've had multiple previous failures, it's probably worthwhile. If you have a history of recurrent pregnancy loss, it may be worthwhile. And certainly if there's any family history of a genetic abnormality, that's a whole other realm of testing that's necessary. And in all of those circumstances, it may be considered as something you should do. But for everybody else, if you're just doing garden variety IVF, the fact or fiction here is it does not appear to be useful for patients that are young, and it may be useful for patients that are older, although we don't have a lot of studies to support even that yet. So I hope you found this really interesting and useful. As always, share, like, comment. We're always open to questions. I'm looking for more topics to do, although next time we're going to be doing supplements like vitamins. And if you guys have something you want us to look into for you and do research on, we'd be happy to engage in that. So I hope you have a great day. I hope you've enjoyed this segment, and hopefully next time we'll be doing it live. Have a great day.